Bismillahirrahmanirrahim. Today, inshallah, we continue some refreshing cases. I wish that you can enjoy with us some long cases. So this is some selected images from CT of this patient. What do you think about? I don't mind if someone want to unmute himself and share in voice if it is good for you. Okay, so but I like you to train yourself how you describe. يعني try to describe in radiological terms like you are in session that you want to report this image in the practice. So for example, you should mention the location and how it look. So okay, Nermeen, I see that you just start to describe this lesion. So hypodense lesion. Marwa also the same. Nice. I mean that at least you can mention that the hypodense lesion here, and you will start to think about some differential. Nice differential. I can say that very nice differential. I see that you put D nut, and you mentioned that is cortical based. So maybe I can show you now the time to show you something else. This patient also, I can tell you maybe some history. So that this patient is 7 years male patient. He is pediatric age group, and he have some earache. Okay, and single seizure. Okay, so you mentioned that maybe infarction age. Huda, we mentioned already the age. It is in the 7 years old patient. So let's have a look in this image. It is the same patient. So what do you think about and how you describe? Start the description as you in radiology practice every day. Okay. I am waiting our stars to give the best description. So Nermeen, the first one, okay, nice. So it will be like a hypodensity here. Do you want to add something in your description? Feeling defect, okay, nice. So it can be thrombosed sigmoid sinus. Perfect. Perfect. That you will search for the cause, that maybe it is mastoiditis here that cause this sigmoid venous sinusitis. Okay. So we have two Ala Muhammad and Ala. Okay. Maybe nice. So at least we have this sign. Okay. So now try to collect with me. We have something in the left temporal, and we have this. So do you like to shift to MRI, or now still you? Yes. Okay. So let's go to the MRI. I will show you the MRI, and we can make nice description together until we reach the best diagnosis. So what? Rosine, welcome Rosine. Nice. As good thinking from you. Huda, nice. So already you can see the mastoid air cells that they have much signals, altered signals, abnormal signals, high signal in T2. And also you can see that the sinusitis already in the ethmoidal and the sphenoid sinus. So this patient have sinusitis and have mastoiditis. Nice. And the most important that what happened here? Yeah, the most important to mention. Yeah, the signal void of the sigmoid is lost. So the signal void in the other side is persistent and in the transverse, but here is lost. This means that the sigmoid sinus has thrombosis. Yeah. When it is transfer from black to white, this mean is not good sign that it is white. مش حلوة عشان انها white. No, it's very bad. Okay. So yeah. So what we can do now, let's shift to another image. I wish that we cover everything here. Now, what about this image of the same patient? Can make some. Okay, so now the time to see. Yeah. Yeah. The same patient, what happened in this image? Left temporal again, and it have like, maybe if you want to describe it in term of MRI, we'll mention that is ring enhancing lesion. Do you agree with me? Yeah. Huda, Muayyad, nice Muayyad, welcome. Nice suggestion. And abscesses, emphysema. Okay. And it is important to have look in this. So what is this? Already you mentioned something related. So it is meningeal enhancement. Perfect. So when you find meningeal enhancement and ring enhancing lesion, I think is nice that you are going that it is now more in the inflammatory side, right? Okay. And with this dural inflammation and this abscess. So abscess with the meningeal enhancement, and there is much affection. Yeah. Okay. Let's go to the last image in this case, which is the B1000 of diffusion. So the B1000 of diffusion, what it demonstrates. Yeah, so these lesions have restriction. So this now give you the impression that this patient have the final, it will be left temporal abscess with venous sinus thrombosis and left mastoiditis. The most important for FRCR that to mention that you make urgent referral for pediatric neurology and neurosurgical teams. Yes. The most important investigation here, it will be MRI, contrast enhanced MRI, as you see, for sinus thrombosis and abscesses. Sometimes they like to show you CT or MR venography. They talk in the management about the intravenous antibiotic therapy and maybe drainage, neurosurgical drainage. If it is non-hemorrhagic cases, they like to give anticoagulant. That's why it's important to comment if there is any hemorrhage in the T1 or in the SWI sequence. So if you have SWI sequence for the susceptibility weighted images or T1, search for any hemorrhage. Then this patient maybe or might be need anticoagulant or thrombolysis therapy. That's why, as a radiologist, you should be careful. If there is any hemorrhage in this case, you should comment it. Also in the CT, in the non-contrast CT, maybe, yeah, you can find any signs that give you if there is any hemorrhage or not. But in this case, we don't have. So likely this patient, he have just this abscesses, as we saw in the post-contrast MRI. Okay. Let's shift to another case. I wish that you enjoyed this first case. So this one is a bit difficult, but we try to, together we can reach the diagnosis. So this is the right kidney in ultrasound. So how we describe it? Marwa, okay, thank you. Right kidney, what happened? Okay, hydronephrosis, Huda, thank you. Nice. And what about the left kidney? I will show you now. The same, yes. So you have bilateral hydronephrosis. So probably they will, the clinician will ask you to do something like this, and the request will come to you, and you probably you like to agree. Nice. So you agree with this request, and you will do this. What is this? His pediatric age group, as you note. So this patient, he's like 2 weeks old baby boy, come to you. MCUG, perfect. This is the examination. Micturating cystourethrogram. He come to you presented with fever, dehydration, and vomiting. And this is what they write you in the request to accept. And you accept. So how we describe now? So let's start that we can, yeah, try to find the bladder. This is the bladder or this is the bladder? Then everyone, I see that Noor and Huda, perfect. You reach it, it's easy. Yeah. So this is the bladder here. Nice. And this is the posterior urethral. So what happened here? There's, try to describe the small bladder, and you can see that the trabeculation, perfect, nice. There is some trabeculation. This means that maybe there is some thickening, and there is hypertrophy of the bladder neck, and there is dilatation of the posterior urethra. So yeah, so this is what is called posterior urethral valve. And the anterior urethra, yeah, there is no contrast in the anterior urethra. And I see that Nermeen and Ala and Huda, yeah, everyone is agreeing with me that there is bilateral hydronephrosis. Perfect. So bilateral vesico-ureteric reflux, hydronephrosis, and dilated tortuous ureters, and even it reached the level of calyces. So you mentioned that it could be a grade 5 reflux. Perfect. So now we can summarize what we should see, that we have obstruction in the level of the proximal urethra and bilateral vesico-ureteric reflux, maybe reaching grade 5, and bilateral hydroureteronephrosis. This is what is called posterior urethral valve. The next step will be referral to the pediatric surgery, urgent referral to the pediatric surgical urological team for the FRCR. They like to mention this in the, okay. They mentioned that the posterior urethral valve, there is 3 types. Type 1, that the most common, the mucosal folds extend anteroinferior from the pheromontana and diffused in the lower level. There is type 2 and type 3. You can read this in the textbooks, any textbook anyway. So yeah, it can reach that it can make neonatal urine leak with ascites, this posterior urethral valve complications, pulmonary hypoplasia, pneumothorax, pneumodiastinum, renal dysplasia. Okay, a lot of information in the textbook. Let's shift to the next case. I wish that you enjoy this pediatric case. Let's have a look in this case. I wish that it can be nice as well. So how is, yeah, let's go to this and try to describe. So this patient is about 23 years old male patient who have acute onset of shortness of breath and hemoptysis. Yes, Huda, thank you. Okay. So try to describe the X-ray if you can. So frontal radiograph of adult male and there is bilateral, yeah, obesities. This obesities, like, is it nodular obesities, consolidative obesities? What do you think about it? How to look? And is it like a central or peripheral? Is it more on the left side or on the right side? So all this you can describe it. So consolidative and nodular, okay, in both lungs, but more in the left side. And they are predominant in the periphery and in the mid zones and the maybe lower zones. Okay, so if you look in the lung volumes, you can see that almost the lung volumes are maintained, but the left side, there is some pleural opacification, especially here, right? So don't jump near me into the diagnosis. Wait, baby, it is not that much easy. Okay. Anyway, so it's pleural opacity and thickening. And before you jump to the description, I will wait for anyone who comment in the lines. So before you jump in the, you should comment in the line. Is it in situ or in proper place or not? So take care about this. So the internal jugular line, central venous line, is well placed or not? Looks well placed, yes. So if remember, we mentioned that at level of carina, you should see it like about 1 centimeter, around 1 centimeter above the level of carina. So I think it's fine. So yeah, it is good in place. So yes, it is in place. And it's good to look if there is any pneumothorax. So there is no pneumothorax. So you like to shift to for CT to maybe if CT maybe can help you. Maybe let's go and see. So there is some selected images of CT, and I wish that we can reach together how we can think. So this image of CT, how we describe them. So the opacities in the X-ray, what to do? Yeah, nodules, and some of them are cavitating. Perfect. This nice description. That's what I wait. Yeah. And surrounding these nodules, there is some reaction in the lung as well. So multiple nodular opacities, predominantly in the periphery as well of the lungs. And some of them, they have thick wall cavitating lesion and surrounded by architecture distortion of the lung. Let's look in this selected image as well. It will be the same description. And you know that most of them are pleural based. Yes. Okay. So time now to jump to the differential diagnosis. Yes. So you mentioned the differential diagnosis, and I see that some of you mention like Langerhans, cell histocytosis, pulmonary Langerhans, and Wigner granulomatosis. That's good differential. So let's discuss, yeah, and maybe metastasis, maybe. And if it is metastasis, you should search for the primary. And it could be like cavitating metastasis like squamous cell carcinoma. Maybe septic. If the patient have any symptoms of bacterial infection or Staph aureus or Klebsiella or whatever, so you have source of infection, or TB, sure. Maybe multiple pulmonary infarcts, and COVID-19 will be one of the nice differential that you can put, Nermeen, nice. And you will search if it is infarction for any pulmonary arterial dilatation. Yeah, that make the infarction as well most likely. So now after you mention the differential of multiple cavitating nodules in the lung, I see that some of you also mention rheumatoid nodules. Yeah, you can put it, but in the, yes, in the end of the, if your differential is not common. And okay, what else? Yeah. So I agree with most of the differential. I think that most of them will be nice to put. Wigner will be nice differential, especially with the history. That's this patient, as you remember, we mentioned that he had hemoptysis. So one of the good differential will be Wigner. And you will ask maybe the patient or check in the history for something called ANCA positive anti-neutrophil cytoplasmic antibody. So this is nice if you mention it for the examiner. Probably he will like you, and also for the practice. If you check this and you find it positive, so maybe it will be the Wigner diagnosis, Wigner granulomatosis, one of the nice tests. Yeah, so microscopic hematuria and the radiological features, especially if you compare it with the previous X-ray and CT and whatever, if it's possible. And for FRCR, you will make urgent referral for the respiratory physician. So Wigner and multiple infarctions, metastatic, all this can be in your top list of differential, and by the history and by the other criteria you can reach.
عمر
Okay.
عمر انت نايم ولا صاحي؟
Okay. I will just mute some of our. Okay. If anyone want to unmute himself and share in the discussion, he will be welcomed. But other side talks is not very. Okay, let's shift to the next case. I wish that you enjoy this case as well. So this patient, the new one now, I will show you. He is about 57, yeah, about 57, 75 years old female, smoker, and she have 6 our history of pain, abdominal pain. So the clinician sent it to you, the request, and he did this X-ray, and you agree, and he did it, and try to describe. So this plain frontal radiograph of the abdomen, how you, yeah, لا, مؤيد. You know, when the clinician send you like this, يعني when he send you something like complaint of the patient, you should focus to answer the question of the patient or the clinician. So if you find anything incidental, you can mention it, but don't rush and put it in the practice, real practice, or in the exam, because of the examiner told you something about the clinician. Then you, for example, you see some lumbar spondylosis and you mention it, or sacroiliitis. I think if you mention it at the first answer, he will be not very happy with this answer. Okay, so take care because in the, especially in the oral exams, for example, he told you that this patient comes to you in severe abdominal pain, and you rush and say that this patient have some sacroiliitis or some hip osteoarthritis. The examiner probably he will be a bit sad from you, so don't do this. I wish that you understand me. Okay, so anyway, now I see the answers, many nice answers. Dilated central bowel loops. Okay, I mean, you can mention anything, but don't start with this answer, because sometimes they, yeah, يعني in Arabic كده انت بتستفزه ان هو يسقطك على طول. Okay, so يعني try to be especially with the examiners. There is a lot of aggressive examiners, so don't try to build this aggressiveness in front of you. Okay, Nermeen, yeah, there is some dilated bowel loops in the middle of the abdomen, and it's good to mention that there is no free gas in the abdomen, so no intra peritoneal gas, no free intraperitoneal gas, so no pneumoperitoneum. Yes, so with dilatation, just dilatation, and you, it's better to mention that small bowel, yeah, like Nermeen, the best nice answer. And there is no gas in the large bowel, as I see in answer of Ala. So now Huda also perfect. Nermeen, nice. So now you will go to the differential. But before we go to the differential, let me show you something in the CT. So probably you don't solve the complaint of the patient. So I think you will go to the CT. So CT abdomen pelvis, and the clinician sent you the again request to find the cause of the severe abdominal pain of this lady. So this is the coronal image, both oral and IV contrast, and let's try to find the cause. So describe it. Nice. I see very nice answers. Huda, Marwa, Muayyad again, nice, perfect. So start that there is ascites and the dilated small bowel loops. Yeah. So surrounding everything. Yeah. Surround the liver, the left paracolic gutter, and the bowel loops, and right paracolic gutter. So surrounding everything. And you can see that the cleft iliac fossa, yeah, Nermeen, nice. There is edematous or non-enhancing bowel loops, yeah, compared to the other bowel loops. I mean, if you compare it to other bowel loops, you can see that they are not very enhancing. Yeah. And you can see that the vessel, the most important, the vessels going to this bowel loops are not enhancing that compared to the mesenteric vessels. Yes, these loops, perfect. So there is decreased bowel enhancement, and there is no enhancement for the marginal arteries that going to the this bowel loops. So I see that most of you is going that ischemia will be the best for this patient, and I think in the axial will be much easier for you to check it. So again, the ascites and non-enhancing, or the bowel loops that dilated and non-enhancing again. Okay, and just a moment. Again, here in the sagittal images, you will confirm that there is decreased bowel enhancement compared to the others, and there is ascites. So the supplying arteries to these bowel loops are non-enhancing. So the best diagnosis for this case will be small bowel ischemia. And now you are going to search for free gas again. So if there is no free gas or no gas in the bowel loops, so this good sign that is early. But if you find like any gas in the bowel loops, so it will be a late and very dangerous sign that it will probably go to gangrenous. So that's good that the most important in this case that you mentioned should be ischemia until proved otherwise. And you search for the gas, and in your description, either for EDIR or FRCR, you should mention the gas, that no gas. So the good negative here, that you should mention no gas, okay? This is important negative. No, it is bowel loops, gas inside bowel loops. I will show you. Either in the wall, okay? This is in the inside, okay? It's not in the wall. Okay. So, but small bowel ischemia, one of the good cases. The like in the exam, in the practice, it can come to you and.
Doctor, this is venous or arterial ischemia?
You know, and it means that it's like selected images. So sure that you would like to check. Let's go again. Maybe we can see if we can find. Is it? I mean, for selected image is a bit difficult to. It's not CT angiography that you have the full phases in venous and arterial phase. But to be honest, I see already the marginal arteries that going through the supplying these bowel loops is not enhancing. I mean, I can imagine that the branches which are going to supply these bowel loops are not enhancing. So I think from this just image, I think you will put the arterial ischemia as first. Yeah, first. So they just a good thing also in the clinical that when the patient come to you that with severe pain, and if the clinician he was clever and so tell you that this patient have soft abdomen, so it's not rigid abdomen. So put the ischemia like the first diagnosis. For example, if request come to you and you were in the emergency, whatever, and they send you that maybe this patient in the X-ray did this and especially when the patient come to you in emergency, surgical and the emergency department. I know that most, like many of us, they don't like to be in emergency situation, but anyway, it is a common case in the emergency, to be honest. I mean, if any one of us was in emergency one day, I think he saw like many cases of bowel ischemia. And usually the symptoms in these cases are non-specific. So you cannot expect. That's why the most important here that when you suspect, يعني, don't take it easy, okay? And look carefully for the mesenteric artery and branches very carefully. And regarding the exam, they like to show you this because, you know, the mortality rate in bowel ischemia is very high if you didn't diagnose it. So if you failed to diagnose this and the patient, probably the mortality rate will increase with delay. So any delay from you will make bowel necrosis and mortality. So yeah, they want to tell you that also there is some differential diagnosis like adhesions, tumors, anastomotic strictures, inflammatory bowel disease, paralytic ileus, which also can be the causes of these symptoms, as you know. But put your ischemia or the ischemia in general as one of the most important cases. Especially if this patient, for example, come to you in old age. We mentioned already that this patient, 75 years old, female, smoker. So all this like risk factor to think about ischemia. Okay, 50% of cases ischemia secondary to thromboembolism in 50% of cases. And other causes include anything like bowel obstruction, volvulus, any tumor or neoplasm, vasculitis, radiotherapy, and trauma. In the early stages, as you see here in the abdomen, it can be dilatation or it can be normal. Okay? So sure, the CT post contrast, as I show you, is the most helpful to diagnose these cases. The imaging features you will search for either dilatation or bowel thickening, neural thickening, bowel wall thickening. Yes, is non-specific, but you will search for, okay? What I told you that you will search for intramural pneumatosis or what is called gas bubbles in the lumen. Sorry, in the wool, not in the lumen, because as I think Ala who mentioned that this could be, but no, it's not. First of all, this is the stomach, and even if it is this one, it is not in the wool, it is in the lumen. Okay? I know that I spend much time in talking about this case, but it's important because in every exam you will find it. Sure that you will find one case like this. Okay. No ascites, you should comment for this case was positive ascites, and the gas in this case was negative, but important negative that you should comment in it. And finally, the portal venous gas. If there is any portal venous gas, sure that it's indicating very bad sign, and if it is present, you should mention. Okay, the engorgement and the thrombus formation, everything, yeah. Reduced bowel enhancement, all these criteria we mentioned already. Okay, let's go to the next case. Bowel ischemia, very important in the exam for the practice, so please be careful about it. Okay, inshallah. Okay, let's go to this case and let's see how we can reach the diagnosis. So this patient is 70 years old, female patient, have a severe benign esophageal stricture, maybe due to acid reflux. And one day she have history of abdominal pain and vomiting. Okay. So this request come to you and you agree to do abdominal X-ray plain frontal radiograph of the abdomen. So what do you describe? What do you see? I see someone want to describe. Yeah. لا. Okay, nice. So again, there is dilated small bowel loops, and you have a scale here already. So this is like a 10 centimeter, if I am not mistaken. So it is more than 5 centimeter at least. So this means it is dilated. Yes. And if you find a small bowel dilatation, you will search for large bowel dilatation. So there is no large bowel dilatation. Huda. So Huda, if you can see, you can characterize that is small bowel, you should mention that it is small bowel. It's not just enough to mention that it is bowel dilated. Yes. So dilated is small bowel loops. Large bowel loops is not dilated in this case. And I see that some of you want to comment in this. So there is something look like a metallic tubular density, have like lattice or something inside the left iliac fossa. And probably there is no surrounding calcifications here. And it's nice when you mention the X-ray of the abdomen to put no free gas. Always you search for it, the gas in the abdomen, positive or negative. So there is no free gas. Okay. No free gas. Okay. And look up for the biliary in the right hypochondrial to mention that there is no gas in the biliary tree. And if you remember the history, already this patient, I told you that have history of something about stent, but we don't have any stent here. Nice. So you cannot see anything. Some degenerative changes here in the lumbar spine. Do you agree with me? I agree. So now what is going on? From the history, try to remember the history and try to guide yourself what happened in this case. Okay, I will tell you the history one more time, then we can remember. So this patient have benign esophageal stricture due to acid reflux, and one day he have history of central abdominal pain and vomiting. Then he did this. Huda, nice imagination. Yeah, maybe. Okay. So good that you at least remember the history, because the most important to remember the history when the examiner tell you, and you expect this. So maybe something happened with this stent. Maybe it was in the esophagus. Maybe it is migrated. Maybe. But at least here, I mean, if you don't have anything, at least you have dilated bowel loops. So maybe your first imagination that maybe this patient have some adhesions. Maybe he did this surgery and he have post-surgical adhesions, and maybe this from the adhesions. And maybe this is another stent related to the rectum or whatever, you know, to clarify more the history and the clinical data, Ahmed. Nice. So maybe. So anyway, in the FRCR, they like you to mention that you will probably this case will need to discuss urgently and with the surgical team, and to see if there is any perforation or any migration. That's nice thinking, especially with the history of the esophageal stent. So you should, for example, if you have any previous MRI, X-ray or CT, you should look in the previous X-ray and see if this one it was here and it's migrated or not, right? So good also to ask about the previous images and to compare the data, especially if you have CT. Okay. and also that is good maybe to require chest X-ray for if this patient, if they suspect that he have any free gas, to include the upper part. Okay, so this was the discussion. Look in the city, because I see that Nermin went to the city. Okay, so this is the city, and they mentioned that migration of the esophageal stent is a bit common. It can happen in about 35% of cases. Yeah. They put the stent in the gastroesophageal junction, and it is like what is called the covered stent. So it looks like something like this. Okay. And it is prone to be migrated. And the history you should suspect, to be honest. And they mentioned that the stent, this stent is placed to migration. They have something called wait and see approach. If this patient is asymptomatic, they wait and see, because sometimes this stent can be passed through the rectum and go alone. If this stent was stuck in stomach, maybe they can remove it by endoscopy. Sure that maybe there will be some discussion about stent migration, like if the complication happen, like perforation or obstruction. That's why it's important when you see the X-ray to mention that there is no free gas. So you mentioned that there is no free gas, and yeah, this stent can be removed surgical. They mentioned that this case was removed by laparoscopy, and successfully they remove it. That's good news. But unfortunately, that this patient have pneumonia after operation. So this was the bad news. Just something nice to know, and it's good to remember the history. So be careful about this again and again. So this patient, another one, who is a 56 years old woman, have progressive dysphagia and past history of GERD, gastroesophageal reflux disease. So take a breath in 30 seconds. Try to refresh yourself. We are not in a hurry to answer it. Okay, I see that there is many answers. Okay, so this like swallow, contrast swallow. If you don't know the type of contrast they use, so maybe you can just mention that it's contrast swallow for the examiner. So there is some narrowing in the mid of esophagus, narrowing lumen, and I see some good descriptions. Look in this also image, and you can continue your description. So Ala, perfect, good description for the first image. Nermin is nice description. Ala, Huda, Now it is seen. You won't see it, okay? I think now it's fine. So narrowing in the mid-esophageal aspect. And there is some outbouching. Yeah, here. They each like very small, you can say that millimetric in size. And they look like communicating. And maybe some of them with narrow neck. About the mucosa, you can see that the mucosal inside, there is no mucosal irregularities. And I see that most of you have very nice answers about the lower esophagus, that there is dilated lower esophagus and there is no featureless lower part of esophagus. Yeah. Perfect. And I think some of you, one of you, yeah, the bronchus is outlined. So this means that there is aspiration. Perfect. Perfect. Nice. Okay. So after all this, you can go to the diagnosis of, I see near mean that it is أو آلاء, both are going with esophageal intramural pseudo-diverticulosis. Okay, pseudo-diverticulosis. There is stricture in the mid-esophagus. There is aspiration. And regarding the dilatation down, so maybe there is esophageal dysmotility or decreased esophageal motility. Okay. So this is what is called esophageal intramural pseudo-diverticulosis. Yeah, intramural pseudo-diverticulosis. What you will do regarding the FRCR exam, they like to mention that there is urgent referral to the surgical or the gastroenterology team. They like to make endoscopy to confirm or to exclude the cause like candida. So they want to know it is candida or not. So they like to do endoscopy and take biopsy to see if it is the candida infection or not. And regarding the stricture, maybe they would like to do what is called endoscopic dilatation. Okay, so this is what is called esophageal intramural pseudo-diverticulosis. Benign disorders, it can happen in every age, especially in the males. Okay, sure that the patient will come to you with the dysphagia, the presentation. Usually it's like the upper third of esophagus. They like to mention that it have right angles along the esophageal lumen. Okay, and it have narrow neck. The neck is narrow and have right angles in the esophageal, yes. And the association is candida. That's why they like to take biopsy to exclude or to prove that it's candida infection. And sure that it can have reflux, as in this case, gastroesophageal reflux. hiatus hernia, esophageal dysmotility, and diabetes and carcinoma. Okay? Okay. So this case was something called esophageal intramural pseudo-diverticulosis. Let's have a look in this case. So this is the breast case. 50 years old woman have bilateral lumps in the breast. So this is the right side. Standard bilateral 2-view mammogram. So you have mediolateral oblique and the craniocaudal views. So this one is like right one, and this one the left one. So I see that starting you comment of the density. So the density of this breast is like type C, which is predominantly dense, more than 75%, I think. Anyway, it's dense breast. And how we describe it? Okay, I will show you the craniocaudal now of the right and left. So the right craniocaudal. So you have like multiple, I see that you multiple bilateral masses, rounded in shape. Okay, and maybe medium density. You remember our scheme? If you still remember, we mentioned this in the previous sessions, especially in the session of mammogram. Okay, and this is the right side craniocaudal, and finally the left side craniocaudal. And you can see that the largest one, it looked like in the left side. If you have, can measure like few centimeters, but good to mention that there is no associated calcifications. And I think you like to do ultrasound. I see Ala, yes, nice, so good answer. So you like to know, is it solid or cystic? So do ultrasound, time to go for ultrasound and see how it look like. So how it look like? Nice, Huda. So anechoic lesion with ultrasound. This lesion is mass lesion, ultrasound anechoic. There is posterior criteria with acoustic enhancement or shadowing. Enhancement. Perfect. And in the right side, they did in the right breast, and you can see that there is multiple similar lesions. So the left one was the largest one. So now, how you make the BI-RADS, which BI-RADS you would like to put? BI-RAD 1, 2, 3, 4, 5, or 6. So which BI-RADS you like to have in this case? Yeah, BI-RADS 2 is a cyst without anything, so cyst, just typical cyst. So this means that's BI-RADS 2, and in the FRCR they like to mention something called M2. So bilateral M2 or bilateral BIRADS 2, multiple cysts. Differential diagnosis, probably if you have this ultrasound will be cyst, but they like in general for just the mammogram to put some differential diagnosis like fibroadenoma, for example. Okay, so the most important here in the management that you ask for ultrasound, as you mentioned, which is the most important to know for discussion, and to know that if you find the cyst, no, nothing will happen after. Maybe sometimes if it is very large cyst, maybe you can do ultrasound and do aspiration for this case and see. Okay. Cyst fluid should be sent for the pathological analysis if blood stained or the cyst doesn't aspirate to extension. Okay. No further action that you need to do. Okay. Take like 30-second break and come back with this case. Okay, I see that you take the break and start answer. Okay, so I recommend you, Sarah, to start to describe better because it's not very easy to just put one differential diagnosis. But okay, I agree that maybe one of them. Amna, nice this description. I see that you mentioned that there is wall thickening, and welcome. And welcome, Sarah, also. I see you are hiding, but okay. So there is some thickening in the bowel loop, and you can imagine that this one, it will be in the right iliac fossa. So is it the terminal ileum? So thickened terminal ileum, and there is fat stranding and smudging. I see a lot. And you will search for any lymph node lymphadenopathy. I mentioned that already you have something here. So okay, I agree with you, Huda. Nice. Fat stranding, muayyad. Maybe it can be one of the differential. It could be a mess. So I think now time to choose another image and see. Huda, I agree with you in the differential. I agree with Sarah again and you, the good differential. So I see muayyad now. You maybe that you like to mention that again, it look like more thickening and mount to be a mass maybe, but there is fat stranding. The good negative that you should put in your description, in this case, the no ascites, no fluid, no intra-abdominal fluid, again, and no gas. Yeah, this terminal ileum is very beside to the cecum. So maybe we can mention if the cecum is affected or not. Let's have a look in the images and see again. And also to mention that the rest of the bowel loops are almost normal, grossly normal. So no fluid filled dilated bowel loops and no signs of obstructions. And you will search for any focal thickening or enhancement. And if you mention that inflammatory bowel disease, one of the causes, so search for something called skip lesions in Crohn's, for example. So you will like to go and search for any skip or similar lesions for this lesion. Okay. And finally, maybe you'd like to check for the sacroiliac joint in the bone window and see if this patient have any sacroiliitis. So it will be important in this case to mention in either positive or negative. So I see from your answers that Amna put differential diagnosis of Crohn's, also lymphoma, tuberculosis. Nice differential. Ala again, the same. Thank you. So differential diagnosis of terminal ileum thickening will be Crohn's, especially if this patient have history of abdominal pain, weight loss, diarrhea, so symptoms of Crohn's. Lymphoma will be very similar to Crohn's, right? And TB, but lymphoma in the small bowel maybe have something called aneurysmal dilatation. And finally, something like infection, like Yersinia. Yeah. And it have no deep ulceration. And it goes spontaneously, resolves spontaneously. So until now, Crohn's will be one of the good differential for this case. Yeah. Or lymphoma. Okay. The TB maybe, but involved the cecum and gave rise to something called coned cecum. We don't see this because you can see that the cecum in this case is fine. So TB will not be your first differential. So Crohn's or lymphoma, one of the good differential in this case. This patient have immunocompromised and you suspect something called typhlitis. Also can be good differential, but in this case, this patient have 30 years old female patient with right iliac fossa pain, so don't have any history of chemotherapy or immunocompromise or something like this. So until now, you can put the top of differential like inflammatory bowel disease. They like to mention for the FRCR that you make urgent referral for the gastroenterology and discuss with him the possibility of to be Crohn's. And probably you would like to see other CT or MRIs to check for the other imaging criteria. Okay, the diagnosis will be a type biopsy. Yeah, I agree with you, Ala, that also typhlitis maybe can include the cecum. Yes, so in this case, the cecum almost fine. So yeah. Crohn's in the imaging criteria, a lot of discussion, and I think that everyone know much information about this. So I think just I will show you the rest of images. So again, the terminal ileum dilatation. The MRI will be nice, especially to search for the fistula, sinus tracts, okay, especially in the anorectal region, and also for abscess formation and so on, okay? Would you like to finish with this case or one more case? Do you still have energy for one more case or okay? Let's have we have 4 minutes. Okay, we can just take last case before we finish for today's session. I wish that you enjoyed. It is more like the core cases in EDIR, and it's more like the long exam cases in the FRCR. Okay, this patient present to you with acute on top of chronic abdominal pain. He's a 50 years old patient. You agree for the request and they did this abdominal plane radiograph. So what do you think? مؤيد, nice. So maybe something here in the mid abdomen. So do you agree that maybe it is not just okay, yes, you mean this one. Okay, nice. So I think that you agree with me that here, yes, there is calcification mid abdomen. Perfect, nice. And there is a surgical suture here, surgical clips in the right upper abdomen. Nice, Huda, perfect. Ala, you mentioned that maybe this calcification, as we know that this is the site of pancreas, so it could be like calcification of pancreas, so denote that can be chronic pancreatitis. And these clips could be like cholecystectomy clips. Okay. The bowel gas pattern is fine, unremarkable, no gas intramural, no free gas, no gas in the biliary tree, the good negatives, some degenerative spine disease. Okay. They like to mention that there is also some calcification in the aortic and iliac branches, as you see here. Okay. So aortoiliac and maybe femoral as well, calcifications. So good, choose a choice that you mentioned that this could be chronic pancreatitis, and sure that you will look in the history if this patient have secondary diabetes. Nice. So also it can the cholelithiasis, the gallbladder stones, and if she did like cholecystectomy, maybe it will support your thinking. And if this patient have acute pain now, so maybe he have diabetic ketoacidosis,